nobody is online, so we go again. So okay, again. So going to the topic again. So everybody knows this is actually happens when we getting into the safety point of view. If somebody has been not sure about MR safety, or they didn't have any education or training related to MR safety and seems to be neglected for safety, this can be happens anything which is not conditional to the safety guidelines, that can be cause damage to the equipment and also the person inside the premises or the patient or who is ever going to be the healthcare practitioner. Some of the incident, this is a trolley or bed and some other hospital related equipments, and this is an oxygen cylinder. So oxygen cylinder is not allowed inside the scanner rooms, so everybody need to be aware of it. Maybe sometimes we'll think about X-ray and CT. We can go with X-ray and CT scanner with an oxygen cylinder, but MRI is not acceptable to go with an oxygen cylinder. And another problem with the happens, we have only if the personnel injured inside, we have to go for a procedure called quenching, which is a magnet turning off or turning off the magnet for the emergency situations for life threatening. So there should be some damage, severe damage by the quenching will happen to the equipment. Also, there should be some hazards we'll be discussing later. So this is a procedure we have to follow while going for emergency procedure of quenching. So the left one, this is actually an Siemens system, and this is a G system, and this is a Philips system. So I used three of the machines here. So we have a Siemens and G and Philips machine. So that's why I put three of them also. So this can be found in the near to the MRI console, or something will be in MRI room also. I think in GE, I found this right side system inside the scanner room, and this is I found in Siemens just near to the console, like or in the console. And this is also I found outside the scanner room or inside the console in Philips. So this all denotes that emergency switch for quenching. So I'll again say quenching is a process which will turn off the magnet power or turning off the magnet for some certain emergency situations to save the lives for the people. Why I'm saying, because there is another option. If we have any other requirements to stop the machine, we have another procedure also. So I can tell that later. So there are another problem. If something which is related to electrical safety, we can, if there is some danger also happens, we can switch off the electrical power, which is not related to quenching, which is we are turning off only the power. As there are two buttons we can see, that is one is on this one, which is an emergency off button, and this is an emergency stop button and emergency off button. So if we have to cut off the electrical power inside the magnet room, we have to press the emergency off. Then if you have to, emergency stop, if you have to cut all the uh, systems which is inside or outside or anywhere within the MRI premises, you have to uh, switch off the emergency off button. So that's we can use in any other situations. So these both switches does not relate anything to the quenching button or quenching system. So only turning off other and associated power supplies to the machine. And then we have another any emergency procedures or cardiac arrest or something related to MRI. We all have to be like, if you are working alone, you're working one or two radiographers or one of your support workers, anybody have to go and call the other people to be in the vicinity. Just for a minute, I have to go. Somebody's on the online. Just give him a admit. Sorry for that again. Okay, so yeah. So then we can call the emergency situation. There should be some code blues or some certain numbers. Didn't specify any numbers here because every hospital, every institution, every country has different rules and different policies, procedures being followed. So I just want to don't want to specifically mention anything here. So just we have to use the site and location where we are having issues. So cardiac arrest inside the MRI department and site, and somebody will be there is a crash trolley outside the scanner premises that can be used for this same thing. And also we have to call a extension number. We can say that emergency situation and a doctor need to be urgent at the site. So this is actually we also follow here. And also everybody has to follow a particular rule which is called local rules, and there are some certain policies and procedures which will be written or which will be inside a computer file or sites with the hard copies available in any other hospital sites. And this should be also found in all staff who is working in the department in MRI should review and read the policies better and to understand. Again, another situation, if there is any emergency situation, we have to use it like we have to use patient should be out from the MR environment immediately and to the nearest preparation area. So start the CPR or any other medical treatment, because we can't bring any uh, equipment which is not conditional to the MRI scanning premises. That is another risk of having issues inside the so that means a research trolley or any other medical equipment or any unscreened personnel must not be taken into MRI environment. That is also hazardous to the department or the hospital. So there is an incident happened which is called a static magnetic field incident. We can say that, and which is happened in 2014. And one patient, the staff brought the oxygen cylinder to the scanner room, and it's been trapped there though. And the technician found inside the bore, so it should be quenched, need to be come out from the patient. Sorry, the technician need to be come out. We have to quench the machine. So this happened in 2014 in India, I think, is in Mumbai or somewhere else. And another incident, which is a floor polisher, which is sucked into the scanner, and we need to oh, ram down, which is another situation. So what the difference between in this situation, I can say. So this situation is a person who is actually alive, and we have to save the patient. We can use quenching so to demagnetize and bring the person to be alive and safely. So only the way we can save him by using that quenching button to press. But in this situation, it is a flow polisher which is sucked into the scanner. So there is another option called ram down, which is actually not.
Srinath,
Hello.
the screen is not visible.
Okay, just a second. Nobody mentioned. Sorry.
I can see.
Yeah, it's mentioned in the chat box. You can see clearly.
Okay,
Could you please pin the screen and make it in the full screen?
just a second. The problem is I'm coming out from the screen for because somebody is joining in between, so I have to come out. That's why. Sorry. Just a second. Sorry, it's a technical issue, I think. It's not allowing me to share the screen now. Is it visible now?
Yes, visible now.
Yes.
Is it clear now?
Yes.
Okay. So this situation is different here. So this situation is called ramping down. So there is less expensive than the conjing. So this can happen the serious injury to the scanner, but it should be performed by service engineers. And but we can save the some of the expense by not conjing down. So this is another situation we can use. So the MRI units always have a potential risk involved inside, and also patients may be killed inside. So these should be given. These documents are actually suggesting we have to be very much clear with safety and training purposes, and possibly a safer MRI magnet room for the other to avoid the other dangers for the personnel or staff or who is being coming to the scanner premises. So my aim here is to provide an awareness of risk when working in MRI unit, and also aware some your responsibilities as a radiographer or category B staff. Otherwise, there is to deduct some training or resources for further reading also. So then there are some other key assessment information is also been shared. Also, some describe about hazards surrounding the MRI and understanding your role in safety. So these all should be as a learning outcome you will be get inside outside of this core session. And I've been following MHRA guidelines and some of the Asia guidelines and some of the other resources being followed. I'll be give you everybody the end of this talk. I'll give the resources I've been used and things I've been research going for the training purposes. So everything I'll be providing in the end. And these guidances are used for best practice for any category of staffs, used for training and requirements. So basically, we need to understand where we stand as a radiographer or like a supervisor or MR authorized personnel or somebody we called as a operator also. So the category B staff should be anesthetists or radiologists or staff nurses, or somebody will be called as a category B, and which is less supervised, like which is should be supervised by somebody else, which is called as a MRI authorized personnel inside the scanner premises. So all the staff should be A and B should be read and sign the local rules, which is mandatory requirement as a MRI departments policies and procedures. And also that person have any other further reading, further doubts, they should be discussed with the designated person of MRI clinical scientists or MR safety personnels. So this picture I'll show you where the category staff A belongs to. So we can see there is a projectile zone an MR environment and MR controlled access area. So if you see, this is a schematic diagram actually I'm using. So this both combined one, this is actually MHRA and ACR combined form. So while in the difference in the ACR, they have a 1, 2, 3, 4 zone, and in MHRA, they are actually only giving a controlled access area and a MR environment. So while within the MR environment, the red lines suggest the projectile zone, and this is a controlled access area where it comes the console, where this we can see that a person who is operator stands. So from this picture, an operator or maintaining or modifying the equipment is called a radiographer, or somebody physicist or service engineer or radiologist also will come under the category A. So where we can see they can go inside the console, they can go inside the MR environment at any time, and any situation they can go and modify and operate the machines also. That staff is considered as category A. While we going to the category B, what the change we can see, there is a into here. So why the into is actually they can enter the controlled access area, but they are not allowed to change or operate the machine, which is some of the radiologists or anesthetists or nurses or somebody healthcare support workers. They are not allowed to change the parameters or anything which is called the operators who doing, or radiographer, or some service engineers, or they are also allowed to do this, but there are other people they are not allowed to do. That is called the category B. Some of them will come under, so we can have a debate there, but some of the radiologists will be come under category B, some of them come under category A. But that is actually a strange debating situation. But I will say we can consider category B is actually best for the radiology, because some of them doesn't understand how to operate the system, how to manipulate the scanner. So we should say under them as a category B. So they can go inside the projectile zone, they can go into the console area, but they are not allowed to do anything on the change of equipment or change of parameter or operating of machine. Then another staff, which is called category C, who are required to enter the MRI environment when the scanning is not taking place. They are actually, we can see why the is into here. They are not allowed to operate the machine also. They are not allowed to enter while scanning is promises. Like when the scanning is there, they are not allowed. While we scanning a patient inside, if somebody coming from a maintenance staff, they have to wait to finish the scan, or cleaning staff will be wait outside. Only we are allowed to them to go whilst not scanning. That's why they are called category C. Then again, another staff coming like category D, which are all the other staff who require to enter the controlled access area, but will not enter the MR environment. So they can't go inside the control like MR environment without any supervision of the mentioned staff above, which is coming either A, B, or C. They can go inside, but the other staff, which is like a clerical staff, they are not allowed to go inside the MR environment without the supervision of the other mentioned staff. And then elaborating these things, I'm going with the MHRA at the moment, because at the moment I mostly follow the MHRA, which is easily to demonstrate, but I can demonstrate it here as a 1-2 sessions of ACR, like a zonal sessions, which is more they're giving like a more information, so easy to follow. For myself, I'm preferably choosing control access area as a zone 1, and then again another zone as a MR environment. So what is actually control access area means? So unsupervised access must be restricted to trained and approved staff for anybody going to the controlled access area, which is actually the red lines being mentioned here. So somebody is coming from the entrance will not allow the key denotes somebody needs an authorized person to be allow them to go inside. So they can't freely go inside to the controlled access area. Why the thing we will discuss in the later. Okay. So example, the control access area means that's 5 goes outside the control access area. We have a MR environment and projectile zone. Also, we can demonstrate it there. So there is another term we call 5 goes line or 0.5 millitesla line in the new version of documents, which says that the MR strong magnetic field can be distributed to the least of at least 0.5 goes outside the like 0.5 millitesla or 5 goes line. Only the some of the active devices are allowed to go inside without any checking. So 5 goes line is a very important line in controlled access area or MR environment. We should be follow only the person who is conditional devices should be allowed above or like allow them to go into the 5 goes line. So that's the one thing we need to be mentioned. So on the projectile zone is inside the MR environment, but 5 goes line is actually the controlled access area also included there. So then this is another layout, which is also like a 2 rooms. If we are going to be in sandwich between a room, which is having 2 MRI scanners, this should be the system. So the projectile zones are marked here, and the red sign denotes the 5 goes line. So if somebody going to inside these without any screening or any supervision by other staff, and they have any not conditional devices, they will be in range. That's why we also need to be checked out. So another way of telling this is a conch layout also. They will say is conch layout because they can see the control access entrance here. So this is they coming inside as a controlled access area. So we can see clearly the boundaries we mentioned. This is a controlled access area and the MRI environment is here. So in that is a schematic diagram because we can see clearly what when you entering a controlled access area, we can see the pictures being put on the door, and also there is to be some swiping cards or some passwords to staff which those are allowed to go inside without any screening. The other staff will not be allowed to go inside, or the patients will not be allowed without completing a safety checklist. This is also another way of telling like zone 1, zone 2, zone 3, zone 4. The same thing, but in different times in ICR manuals. So this again, same thing. I'm just showing because easy for the people to see. So the doors should be always the magnet is on. That's the thing actually we need to I'm just telling these all things because somebody is not familiar with MRI scanner. They should think about why the MR magnet is always on. There is no stopping of MRI magnet, and also the magnitude of the machine will be always have the 5 goes line. So any control like conditional devices, not conditional devices, go inside there should be having potential risk. And another thing we already discussed the projectile zone. We can see in the MR environment where the machine is actually situated. So this is a projectile area where the maximum spatial gradient is actually exposed. So the spatial gradient and fringe field are the both main things we have to be discussed while discussing about the magnitude of the machine. So oval area within the magnet room denoted by a red line in the floor is actually called as the projectile zone. So where the maximum potential projectile risk of the machine is actually situated. Every control devices like conditional devices like equipments which is not the within the personnel, which is outside the personnel as a equipment to support the MR scanning, which should be outside the control premises like the projectile zone. So because that can, if we move to more closest to the projectile zone, there should be hazard will be occurs. And this is a preparation room. So if somebody is being prepared outside the MR environment will be keep there. So there should be monitoring equipment will be stored here, and also we should check the safety and pose is actually another term in MRI, which is we before going to the room we have a safety checklist of documents to be seen before going a patient into the scanner room. And even of cardiac arrest, the patient should be moved from MRI environment to this region to start the processing of CPR or any other kind of life-saving medication. So what I'm saying about the post means to be we have a practitioner checklist for MRI safe examination. So while doing it, so if you are going for a scan, we should confirm the patient ID, and the examination should be justified, and we should check the previous MRI safety screening things, and all the other preparation should be checked, and the patient condition should be checked, and all other things will be checked. And next thing we have to think about anatomy, which coil is we needed for the scanning, which part we are going to be scanned, and is the requested part should be the same, and we have to follow those also things. And user checks, so we have to be check the machine and protocols, and the vetting means actually in which is a radiologist or somebody as a senior staff should be say which is the protocol to be carried out for a scan, and that is called vetting. So that's another term in used in UK basically, or any other country also may be used. And we have to check the intercom is working, buzzer is working, the machine is working, no other problems, and renal function if the contrast is giving for the patient. So these all checks will be done by the user before carrying out the scans. And then we have to check the systems having the ID and the patient's weight, which is very important for the SAR point of view, and confirm the protocol and coil selections are clearly done. And exposure and the MHRA guidelines, we have to follow the guidelines and things to give the specific energy dose or SAR limits for particular kind of scan, or like a normal mode, first level mode, or whatever we need to be done. And after doing the scans, we should confirm the image quality by checking the images and confirm the examination images all being completely accurate and is no without any motion or artifacts or something we have to repeat or not. And inform some of the centers will be having packs, they will send the images to the pack, some of them will be printed and saved, and some others are different. So these should be checked. So this is a very important document. Before going to the scans, we have to be follow this called post. This is a release by SOR, which is a Society of College of Radiographers in UK. So I'll give a few seconds for next session. Few more. This is a long talk, so you have to be like a 1 more minute rest for others. Feel free to talk anything in between. Yeah, following the talk, or any difficulties or listening, or any problem you can say now. If everybody can happy, we can continue with us. Otherwise, 1 minute break for them. I can check the messages if somebody has any messages. Nothing. Okay. So I'll go again. Okay, so before going to the scanning, we have called a safety questionnaire or screening form. So I am just sorted out our safety forms and things into a little bit form to understand this. So we have to check the preparation and minimize the risk associated with the scanning. So correct identification and safety screening procedures to be followed. So must undergo safety screening prior to them environment, not the actual have to bring the patient inside the MR environment, and going with the safety is not a safe practice. So we have to follow the safety and questionnaire before entering the controlled access area, because 5 goes line, wherever the 5 goes line starts, we have to only screen the patient before the 5 goes line. That is a very, very essential thing, because somebody has a for conditional, non-conditional devices like active devices, which can cause harm to the person who is entering this premises without any questionnaire. So somebody is not answerable or not communicating, we have a procedure followed in this. Our hospital follow the procedure which called, we have a particular X-ray. We do a skull X-ray or CT of the if the patient is admitted on the hospital from the day of admission, and the doctors understanding the patient has no implants or safety hazard to go for MRI, they will sign off. Otherwise, we have to follow a particular kind of X-ray, abdomen, chest, pelvis, and also CT. Sometimes we have a CT available. We can use a CT for checking the no contra indication for MRI scan to be carried out. So that's a thing we used to do in our hospital for non-communicating patients to be scanned. And another thing is actually we have to use padding. Padding is actually minimizing the risk of burns within the skin-to-skin contact while going to the scanner, avoiding feet together, hands touch the body parts, and the hands touching the bore. So we have to avoid all these kind of things by giving the pads. Proper padding will be easy, and especially with the body habitus, people are like a bariatric or somebody, there is a more chances of SAD or SAR should be deposited for them, and we should follow the padding for, especially for a must provide thing for the bariatric or high BMI patients. Another one is a hearing protection. You have to give the hearing protection because MHRA has really influenced into that, because above 85 decibel, everything should be given as a hearing protection. So use the hearing protection as much as possible for muffs for these pediatric patients, or earmuffs or earplugs, which will be given also soundproofing different like headphones. Also some of the centers will be provided. And MHRA has defined modes of operation: normal mode or first level mode or research modes inside the scanner. So we have to use different modes for operation, which is best to the clinical condition and the implant specifications. So one of these, some questionnaires has been checked. Why we are asking the questions? Have you ever had a heart pacemaker or defibrillator? So I'll say that if somebody has a pacemaker, in fewer like when I started MRI scanning, so I didn't know that anything we scan with a pacemaker or defibrillator. So now the systems been advanced and the images been scanned previously before the MRI, and after the MRI has been we've been achieved a lot now. So we can scan a pacemaker which is conditional up to the standards of the guidelines followed by MHRA or any equipment manufacturer. So we have to follow some sites, which is mrsafety.com, or which is otherwise called mrisafety.com's list. We can check some conditional devices there, make and models. We have to check the make and models of the conditional devices there. If they are suitable, we can go with them. Otherwise, always check the equipment's manufacturer's site and check this serial number and model number for particular devices like pacemaker. We have legacy pacemaker. There we have a lot of Albert pacemaker, Medtronic pacemaker. A lot of different manufacturers come with the different equipments, different conditional equipment. So we have to follow that, checking by their sites, not in the Google by everything. So we have to follow, like some of them, I should say some of my colleagues even check the safety by Google, but I don't think so that's a safe practice to do, because if we can say by like conditional this to be met only while we follow the equipment manufacturers guidelines, otherwise we have to follow officially declared documents from MHRA or particular MR safety, any authorized sites. Otherwise we are going to be in a risk, because if you follow checking Google and safety, then you can give a false information or AI generated information that can lead to the patient a risk. So we only follow the guidelines which is in the equipment manufacturers or otherwise safety authorized persons. And another question is a heart surgery, heart valve replacement. Previously, we can't scan the patient with heart valves. Now, the conditions if we met, we can scan the conditions. Conditional devices been introduced into the MR as per generic implant safety policy. So we use the generic implant safety policy for cardiac loop recorders, which is also undergo MRI examination. Sometimes we can, but the latest cardiac loop recorders will be used for like a data retrieving before the scanning, and after the scan, they will start again data recruiting. So stents also, some of the stents we can scan, but we should follow some guidelines also. So there are guidelines, majority of guidelines says SAR level limits and how much we can scan, how long they can be scanned. The same happened to the implants in the eyes, ears, spine, anywhere. So I'm just giving only few more questions. So everything is actually, implants need to be carefully checked against the policies within the hospital or other further investigation. We should follow the investigation, and conditions are met, only we go for the scan. Otherwise, we don't go for the scan. That's the safety things to be done. And otherwise, they have patients coming with aneurysm clips or aneurysm coils. There are some devices which is look like an aneurysm coil or aneurysm clip. We have to find out which is a coil, which is a clip. I'll show you some examples while later going with the scans images on. We can clearly identify the differences between aneurysm clips and aneurysm coils. So every aneurysm clips are not safe for the scan. So we have to follow the conditions to be met. If you check in the Google, it will say, oh, it's safe for going, but it's all scans, like all the aneurysm clips are not safe for scanning. So we have to go follow the conditions, which is condition will be sometimes the goes in like spatial gradient, how much we can go and how far we can go and how we have to go in inside the room, in the table even. So everything is not same. The spatial gradient levels in the inside room, we should be followed while checking the conditions only. Otherwise, we are going to risk the patient within the scanner room. And same thing happened there. Some of the patients been going with unsafe aneurysm clips and results in patient death. And aneurysm clips requires careful investigation to determine the conditions. That's everybody remember inside, aneurysm clips are not same aneurysm coils. Aneurysm coils are different, aneurysm clips are different. So we have to check with the safety before going in. And another implanted medical devices like we have to follow like some bone fills, plates, pins, and hydrocephalic shunt or gastric bands, eye implants, neurostimulator, cochlear implant. We have so many different kind of implants inside every patient's now. So we have to follow particular safety documents or policies for follow each and every implant, and specifically have to follow the guidelines been mentioned there. And only if the guidelines meet, especially with the manufacturer conditions, then only go for the scan. And shunt, we have a non-programmable shunts available, programmable shunts available, gastric bands, which is not in like sometimes after the 1990s, we are accepting, and some within the period we are not accepting. So we have to follow some certain year-wise specifications for some of the shunts, and which are not programmable, we have to go for straight away. Is not safe. Some of them is not safe with the before 1990s, I think. And also infusion pumps are with some of them coming with, I have been seeing some infusion pumps being sent for the scanning. They've been having inside guide wires, and which is MR non-conditional MR equipments, and which is risk to the burning issues for the patient, not the projectile risk, but they have burning issues. Also, cochlear implants, not every cochlear implants are safe. We have to check for the safety and guidelines, which is mentioned in the manufacturer's guideline before going for the scan. So there are a lot of neurostimulators also same. We have to follow the things. So I'm just quickly going because it's long detailed documents to be short for you. That's why I'm going a little bit faster. If you have any doubts, we'll discuss in the later part. And if you have another question come to the MRI safety questionnaire, definitely metal fragments inside the eye. If you have a metal fragment inside your eye, if they are coming to the MRI scanning, we should check if it is being removed in a hospital. If it is not removed in a hospital, we have to follow for an X-ray orbit to identify whether it's there inside the eyesight or in the premises of orbit. If they are found inside the premises of the eye orbit near to the orbit or optic canal, we have to remove it. Otherwise, they're going to be risk within the scanner room. So these are the things, some questions. I'm just only selected some questions. We have a lot of questionnaires been asked before the scanning, but I'm just giving some examples for the basic people understanding. We can go for another section or another day for discussing later in the future. So then I am following the guidelines from MHRA, which is giving example. We seen actually the control access area and MR environment, MRI projectile zone. So these are the defined areas within the MR guideline by MHRA. So I again showing the same thing. So we can clearly see in the projectile zone is here and MR environment is here, and these all called the red line denotes the MR controlled access area. So we should clearly understand what are the differences within the picture. And SCR also have a SCR 1, 2, 3, and 4 guidelines. If somebody want to follow the SCR, they can follow the SCR, or somebody want to follow MHRA, they can follow the MHRA. It's only the thing we have to be minded, we have to be in safe and knowledgeable while scanning. I'm not telling anybody want to follow MHRA, anybody want to follow SCR. So it's up to their decision and their belief. Again, discussing the same thing. So if somebody's going to the control access area, should be monitored by a personnel which is having knowledge in MR safety and all called as an authorized person. So unauthorized staff should not be entered without screening. So same with the MR amendment, which is actually a Faraday shielded volume within the contouring of MRI environment, which is having a 0.5 millitesla or 5 Gauss line range. This volume or the range might be possess a hazard to the active devices, or electromagnetic field can be alter the equipment and accessories. So again, going to the projectile zone, if you going to the projectile zone, the risk is actually it can having a projectile risk to the equipment or the implant or anything which is ferromagnetic will be having a attractive forces to the scan room, and consequently MR controlled access area is not that much risk involvement, but MR environment is actually the most risk involvement area. So who are authorized personnel? So authorized personnel, which is, we have a just small differences when you checking the non-MR environment. Authorized personnel can enter the MR environment only with the supervision. That's only the difference. So they have to be supervised by a other person, which is actually authorized person. And this is all non-MR authorized personnel cannot be go without any safety screening done by an authorized person in the MR environment. So they can go in the controlled access area, but only they can enter with the supervision from another authorized person who are supposed to be a MR operator or radiographer or any other service engineers. Also, we have a designated term for that. Some of these local rules will be mentioned in the department, which says who are the authorized personnel, who are the supervisors inside the scanner room. So what are the different hazards we've been associated with MRI? We can see how we have a when we go into the MRI premises, we have a strong magnetic field, which is the static magnetic field there, and radio frequency when we scanning, and time varying magnetic field, which is actually the gradient field magnetic strength. And also acoustic noise is also one of the risk or hazardous thing, and cryogens with the helium and nitrogen. And then we going for the MHRA recommendations. The MHRA recommendation says, so we can only allow the devices are conditional within the MR environment, which is unlabeled, should be considered as MR unsafe. So every devices which is only labeled are going to be conditional or MR safe, should be allowed to go inside the scanner room or MR environment. Otherwise, they are not allowed to go as considered as unsafe. So example of static magnetic field, we already seen some pictures, so I'm not going with that. And another poses risk within the static magnetic field is actually attractive forces or torque forces within the MR environment. And also they have some biological effects, and also interaction with the implant and medical devices, also interaction with peripheral equipments. So this is things will happen inside the static magnetic field. So which is depends upon the fringe field, and the fringe field, the extent and intensity of the fringe field is depending upon the main magnetic field strength, and it will be open or close bore, and both are different, like a 1.5 Tesla, 3 Tesla have different field strength, and that will be different in fringe field strength also. And shielding also differentiate, the shielding will be different, and that shielding also different define the how much the fringe field, also how much the risk will be associated with the machine. And all staff should be aware of fringe field strength and spatial gradient. The spatial gradient and fringe field are the differences. The spatial gradient is actually the rate of the change of the magnetic field with the distance. That's the main thing we have to define as a spatial gradient. How much the distance from the machine is actually reducing the spatial gradient. How much you going away from the machine, that will be reduced by dB by ds. That's the spatial gradient. So if you are going closer to the scanner, there is a higher risk of spatial gradient. If you're going away from the machine, is a lesser risk of spatial gradient. So that's some of the conditional devices not allow more closest to the scanner. Example, like we are using a pump injector, we are using a like a monitoring devices or anesthetic machine, which is conditional devices, or some of the ventilators, which is conditional. Those machine devices are not allowed to the scanner more closer, because this spatial gradient will be causing some risk to the equipment. Again, a picture, I'll show you the picture in very detail, so you can see how the orientation is been marked. This is a map of a spatial gradient, so we can see how the difference in the spatial gradient is going with the time. So sorry, distance. So if you're going closer to the machine, you can see there is a mark, so say 200 millitesla, then is gradually going to 40, 20, 10, 5, 3, 1, and 0.5. So the 0.5 millitesla is denoted as the 5 ghost line. So anything active devices are not allowed to above this level. So if you go with within that range, allowed to within that range, it can cause hazard to the personnel or the equipment. So just want to clearly understand how the spatial gradient is distributed inside a scanner. If you're going to the MRI scanner, you should be have this picture in your mind, and this should be having easy to understand how the safety standards. So if you want to specifically know the space, the gauzes, you can convert this millitesla into gauzes. So because it's newer machines coming with the millitesla, so we should follow the millitesla now. Previously it was gauzes, in now it has been changing to millitesla. So what are the biological effects happens is a vertigo happens, and nausea, some metallic taste will happen. If you go to the 3 Tesla or higher ranges, you can test the metallic taste like a battery test in the mouth. Also some of the light sensitive, like a blurring of vision will be happens inside the bore when you go into the lab. And also which is patients being experienced by peripheral nervous stimulation. Also some of the scans will be experienced as a peripheral nervous stimulation. Also attractive and torque forces, which are ferromagnetic materials, which is going to the MRI environment or spatial gradient, will be having a strong attractive forces to the machine. And from the ICNRP statement, which is International Commission for Non-Ionizing Radiation Protection, says that there is no serious health effects till exposure to 8 Tesla magnetic field, and which is not having any serious health issues been denoted for the personnel who is being scanned or who has been entering the MRI room. So only some vertigo or head body movement will be shown, or unpleasant sensory effects will be there. And then having interaction with the implantable medical devices. So if you go with a ferromagnetic component which is non-conditional or which is not safe, which will have attractive forces, that's the same thing I mentioned about aneurysm clips and other devices. And also it has a torque forces that can cause the tissue damage, also implant device, also personal damage. Another example is International Energy Commission or International Commission for Non-Ionizing Radiation Tracking. They all say that there should be a peripheral nervous stimulation. I already mentioned the peripheral nervous stimulation will be there, because while it's scanning, it denotes inside the machine. It says, or patient can experience a peripheral nervous stimulation, but these are not against cardiac defibrillation. So otherwise, it will not give anything to cardiac defibrillation. So all the scanners have been safe for the peripheral nervous stimulation up to a level, because 100% peripheral nervous stimulation also sometimes will apply, but this will also protect against cardiac defibrillation. And another thing is actually, everybody knows that acoustic noise is actually the noise from the machine, which is happening because of the Lorentz forces inside the gradient coils while scanning or while in operation. So we have to use the hearing aid or any protection to reduce the risk from the acoustic noise. And another thing is the radio frequency magnetic field. While we scanning, the scanning when the scanning is processing, we can have a radio frequency in there, so it will create a thermal heating and induce current burns and contact burns or RF interference with the medical devices. So if you have an implant and you have been scanned and you have been giving non-conditional guidelines, you are not following the guidelines being set by the device manufacturers, it will cause a burns. And also, if you are not providing padding properly, if you are having a contact with the cables, or if you are contact hands together, your feet together, these all causes burns in the person. So in MHRA guideline, if you go to the MHRA website, you can get these all things. I'm just showing this because these all information is available on the online. So this is the radio frequency magnetic field modes. We have a normal mode and control mode and research mode. So the whole body SAR levels, which is specific absorption rate, is if you go for normal mode, it is 2 watts per kilogram. If you go for a first level, which is 4 watts per kilogram, and if you go into experimental mode, it is above 4 watts per kilogram. That's the basic SAR levels for RF pulse should be experienced while scanning. And the head levels always, if you go normal or controlled or first level, it should be 3.2 always. The same thing we have to be follow normal mode first level and second level mode also there, so it's just safe. And safety signs, you can see everything like a safety sign boards now. So the easy to understand, the green one, the MR safe, which will be denoted as a labeled as this MR safe. All the things are safe to go inside, like an implant, or implant does not say it should be inside the patient, but other equipments which is safe are labeled as safe will be safe inside the scanner, like a wheelchair. Some of the wheelchair, trolley, these all will be having mentioned as a label, already can enter the room. Otherwise we should not enter. Even it is mentioned as conditional, can up to the conditional levels, like the projectiles within the projectile zone, not cause to the scanner premises. If you see something is conditional, always remember it should not allow above the projectile or should enter the projectile zone. Just keep it in mind for safety. And if you are seeing some of them are safe, we can go clear to the scanner without any problem. But if you see anything unsafe, don't put it into the MRI environment or MRI room. If you are not seeing any marking, is considered as MR unsafe. That's the main thing you have to be and understand. Again, says earplugs and ear defenders should be needed for the person to be scanned inside the room. So because it gives more than 85 decibels to be inside the scan room, and also process some peripheral nervous stimulation, which can goes to the and also if you hearing too much noises can cause some tinnitus, or patient having hearing problems if you are continuously getting the noise. So conclusion of medical devices which are being implanted, it will be just a small information. Implanting clinicians or manufacturers advice should be always need to be assessed, and patient without implantable devices should have to be followed by local policies. Wherever possible, should be checked, double checked to ensure that all are safe. And also, if it is not labeled or anything, you should assume as unsafe. And if you are in doubt, not scan. So this is just some clinical studies. I'm just giving these all as a basic idea. I'm not going with all the information at the moment because it's too much time taking. So even we have been cross 1 hour now. So I can give some more information after the talk or any discussion. I'll ask you and I'll show you some of the information now, but after your queries or any questions.
Thank you, Srinath.
Okay, thank you.
Thank you. Could you please explain? I got the part when you said about the normal modes, the research mode, and all the values were quite different on that. Is it the same MRI? Is it?
Yeah, I'll show you. I'll tell you that. So normal mode is actually if you selecting a scanner, if you go to the MRI scanner, you have an option to be select. If you enter the patient details there, if you enter everything patient detail, then your next option is to select which is your mode, to scan. So if you are going to the GE scanner, you should select as you can select option low SAR mode, like less than 2 watts per kilogram. And also you can select a normal mode, which is 2 watts per kilogram, or also you can go for a first level mode, which is 4 watts per kilogram. So by selecting this, what is you are doing, the SAR levels will be changed every 6 minutes within the scanner. SAR is actually an assessment of a patient's energy deposition, which is specific absorption rate. That's a measurement of energy deposition within the body. So if you can calculate whole body SAR, which is called a specific energy dose. While we are scanning a patient, you completely scanning a patient for an hour, and in the end of the scanning, it is called a specific energy dose, which how much your energy is given to the patient. It also depends upon the weight of the patient. If you enter a wrong weight for the patient, if you are scanning a patient which is 50 kilogram, if you entering 100 kilogram, the patient will be experience more SAR. So that is again also very critical thinking needed. Some of the scanners will have to be under the weight and also the height of the patient, which will be calculate the height and weight of the patient. In Siemens, we should enter the height and weight. It does not allow you to scan after if you are not entering proper height or weight. In G, you can scan with the weight itself. You don't need to enter the height. And also Philips machine, you don't need to enter the height, but you have to be understand with the differences in first level. If you're going with an implant, if you're selecting a first level, which is the machine, the implant manufacturer suggests it should be scanned in a like normal mode. If you go for first level, the SAR level will be 4 watts, and it is not acceptable to the implant, and you can create a risk of burning or the problem with the patient. If you are the main thing while you putting the patient into the scanner, there are some, that's I'm telling you, the projectile and the burning risk, that are both are different. If you are putting a patient inside a scanner, that implant is safe. Like example, you have a coming with a patient with a knee implant, like a knee replacement, that having already discussed, like a general implant safety policy wise, it is safe to scan, and you are putting the patient inside the scanner and you are scanning a knee, and you don't putting as a normal mode, then you start scanning, you are giving more SAR level to the region, and it can cause a burning also, because if the implant manufacturer does not specify it should be scanned in 2 watts, otherwise you scanning with 4 watts, it can cause issues.
So my area of work is X-ray, but I have only a little bit of
It's
experience
fine,
in
it's fine.
MRI.
I'm just that's why I'm giving like little bit more elaborate discussion.
Yeah, thank you. So I have never selected a mode, but I remember I used to enter the correct height and the weight and everything in Siemens machine. Unfortunately, I never got a chance to select the research mode or that kind of thing. But so it also in I think if it is more of an SAR value, then I think it would be like great image resolution, image to signal to noise ratio.
What is actually the signal to noise and other things are different, because the first thing actually we have to think about while we have an implant, it is a safety. The first thing we are discussing, the safety actually the prime important. If you are after that things, everything we coming as a while we start scanning. So even if you scanning with the patient with an implant, your first aim should be safe for the patient rather than getting the quality.
Yeah, true. Thank you. Thank you. That was helpful.
Any other queries? So somebody's mentioned as what is your view regarding off-label pacemaker? Okay, so off-label pacemaker, it is Renew Glucose. Is it Renew Glucose is available? Renew is available there? Yeah, I'll say the off-label pacemaker. Off-label pacemaker actually we do scan the off-label pacemaker, but it should be having some certain conditions. Conditions means every pacemaker we have some certain policies to be followed. I'll share another document regarding the pacemaker. So how we scanning the pacemaker, we have a document. I'll show you that document. So is anybody can see the screen now? Is anybody can see in the screen now?
No.
Just a second. So this document I'll share. This document I'll share now. So this is actually a policy we follow for scanning the pacemaker. So can you is it visible now?
Yes.
Okay. So whatever the document says, we have a condition to be followed. If you're scanning the pacemaker, we should check it is not acceptable thing. There should be three different criteria. So first we think as a low risk unconditional thing, and another thing is actually as a non-conditional low risk. Then we think as a non-conditional high risk. So these are the things if it is an off-label one, we think as a high risk involvement, non-conditional equipment, that should be discussed only with the benefit and risk assessment with the cardiologist or the concerning referrer who required the scanning. So on that conditions, we should assess whichever is a benefit to the patient. So if the patient need to be the scan is the most urgent thing, rather than the patient risking, we should go for the scan. Otherwise, we should have finding out whichever is a less risk for the patient condition rather than going for a scan, we should go. So if the conditional, like if the conditions, the referrer says it should be scanned, and then we have to be discussed with the cardiologist's opinion, and we should be going with the higher risk. We have a high risk of patient having difficulties inside the scanner. Also, we should ready for the emergency procedures after the scanning. So which will be assessed only with the, like we called as a multidisciplinary team meeting. So before these scans, every multidisciplinary team meeting will be assessed. Then only we go for the scanning. It is in the case of off-label pacemakers. And somebody asked about the pregnancy. So in the pregnancy, we have actually a trimester rule. So the trimester rule actually followed as first trimester, we don't go for the scans, and it's again a risk versus benefit assessment should be assessed. Like a conditions like sinus venous thrombosis, we should follow the risk versus benefit assessment. If the referrer needs the scan, we should go for them and tell them the risk actually is the burning issue with the pregnant more than any other risk. And if you go for the again another risk of coming inside the scanner is a noise, acoustic noise, which also in the first trimester is not allowed. After the first trimester, we will go for the scan with some conditions, which is the patient will be having padded with every almost possibilities, and will be safe to ensure that there is no heating or any burning issues been touching to the skin surfaces, going with certain position which is safe for the patient. And also we should go for the normal mode for reducing the SAR levels to avoid the heating. That's the thing of we going with the pregnancy conditions. Any other questions will be discussed, or otherwise we can wind up the session.
Thank you, Srinath. It was quite useful for me.
I have some other documents to show, but this is very long session, so that's why I didn't want to say.
Yes.
So I think I have received some messages to say that it should be in the Malayalam.
Yes. Sorry, guys, we are all on the work. So in here, no Malayalam, no mother tongue. Sorry to say. And it would be great if you could send me the slide presentation via email or something.
Too.
Thank you.
Yeah.
And yep, thank
Please
you.
also share.
Thank you for the session. Bye-bye.
Okay, thank you. Bye.
Quite nice. Thank you for the pictures.
Thank you.
It's